Hey everyone, thanks so much for joining us. Okay, so welcome everyone to today's webinar on the topic of facing mealtime challenges. We are thrilled to have Kristen Conkle with us here today presenting on this topic. I'm going to let Kristen introduce herself because she will do a much better job at it than I would. So I just want to go over a few housekeeping rules before we get started. So if you notice you are muted and you do not have video on, that is very intentional. So we'd like you to please keep your cameras and microphones off for the duration of the webinar. And also, if you have questions, and we really encourage you to have questions, you can use the chat box and you can put any questions you have in there. And then at the end of the webinar, we are going to answer them, as many as we have time for. So now, again, thank you so much, Kristen, for being with us today. And we're going to unshare our slides and then you can share yours.
All right, great. There we go. Hello, everybody. Welcome. It's so nice to be here. My name is Kristen Conkle, and I am from San Diego, California. So it is morning time where I am. I am a licensed marriage and family therapist and the co-manager of the adolescent program for the UCSD eating disorder treatment and research. I have been here about 13 years and I have been in the field for roughly 18 to 20 years in mental health. My primary, what I've really focused on as I've been working here at UCSD, has been around the families and the parent dynamics, as well as the multifamily part, which includes like the meal coaching and the family education. So here at UCSD, we have two days during the week where we actually invite the parents and cares and family members to come and get parent training. We do parent nutritional training. We also do dinners with the families where we do mealtime coaching and kind of teach these interventions in the moment, along with like having more discussions about like foods and different things that are coming up. We also have a full Saturday program here where the families are here for 2 meals, and we do the same thing. We do parent process and we do different types of mealtime coaching. It's really where I have found a lot of interest, and I'm really hopeful that this presentation will give some light into some ideas, some suggestions. Everybody is different and everybody, has experience and tried different things, but I'm hopeful that this will maybe lean into some things that might you be willing to try. Um, and I want to preface, I do have a couple videos in here, and they talk really slowly and lightly. So you just might want to turn up your volume a little bit when I get to that part. And then I'm happy to be answering any questions at the end. So we will move forward. So, we are going to be talking about different theories and principles that guide meal coaching. So, just to start off, a little bit of background of kind of where some of these interventions and strategies have come from. So, we talk about family based treatment for anorexia. Now, this presentation, some of it might lean more on anorexia nervosa restricting type, but I do bring in bulimia and RFID strategies as well. So, hopefully, and some of the other subtypes that go along with some of the disorders. So hopefully this will touch on a little bit of everything, but primarily with family-based treatment, it originally started with anorexia restricting type, and a lot of research came from that. So that is essentially why it kind of is labeled with the anorexia nervosa. So we're going to talk a little bit about that modality, parent management training as well. I'm going to just give you a little bit of info on structural family therapy, learning parenting styles, because really nobody teaches us about these parenting styles or what this even is until we're in situations where we need to learn kind of how we work as parents. What is working for parents, what is not working for parents, some of the mealtime strategies, and then I'm going to touch on some behavioral contracting as well. So, structural family therapy. Family meals basically have been integrated since the 1980s within this field. Structural family therapy was developed by Minuchin, who I'm going to talk about a little bit, and Maudsley, which is FBT, family based therapy from the Maudsley Hospital. So they kind of came together and found that, okay, families really can do this. Like families really, we need to educate, we need to support, and families can really do this. And it really works best when the families and the clinicians really work together. And that's essentially what family based therapy is. And it's really inspired by Benuchin, who did structural family therapy, which really talked a lot about like hierarchies and within the family system. So hierarchies might be just like who has the most power within the family, who is kind of running the show, who is maybe having more difficulty. And that's for just all family systems, not necessarily eating disorders. But they learned that that hierarchy really plays a role with eating disorders, especially when our kids are very sick and we are doing anything we can to get them to eat and get them to do what they need to do. And we will do about anything. And the hierarchy shifts in that moment. And so we really take a look at, and the researchers really took a look at how we can shift that so we can empower parents and caretakers to be able to do the hard thing, which is essentially to refeed and to feed their kid. And so the placement, which the family members is the influence of the behavior is shaped. And then we're going to talk a little bit about that too, in the sense that, when the power dynamics change or shift within the family, then new behaviors can be learned and shaped too. And that's again like systems and family systems, not just eating disorders, but it definitely plays a role when those hierarchy and those power dynamics are changing. So, a little bit about family based therapy. So this is what I was kind of mentioning is that family based therapy, the Maudsley method, if you've heard of that, are clinicians working alongside parents, caretakers to achieve the treatment goal. So this is not that, yes, the clinicians might have like know the research and might know the clinic, the therapy language, if you will, but the parents really know the work. You guys really do know your kid, you know your family, you know the way you work, and you know your mood and temperament, right? And like some things might work for you, some things might not. And that's really where the collaboration comes from. So it's really about like respecting the clinicians, really respecting the parents and caretakers of like, hey, this is what I think we should do. What do you think? Because you really do know your kid, you really do know yourself. Building trust with the teen and the parents of learning and teaching the parents and the caretakers on what to do. So then the teen can build some trust because when the eating disorder comes into play, trust is really challenging on both sides. So the idea of really building that up is important as well. And then the empowerment to refeed and do this hard work. It's very time consuming. It's a lot of really emotions come into play when your child is sick with the eating disorder and you are struggling to get them to eat and there's medical complications and there's a lot of feelings that can come up with this that are very difficult to maneuver. And part of FBT and our job is to help empower and support parents and caretakers to do the work. So within family-based therapy, what we do is we actually, and this it could be like on an outpatient model. So if you have an outpatient therapist, not necessarily just here at UCSD, but there's family meals involved. So as I was mentioning that here at UCSD, we do family meals in-house, like in the clinic. So we do those with the parents and the caretakers. In outpatient, they also do that because having meals with the families are really important to see those hierarchy shifts, to see how things are being done, what's being said, how the family works, what maybe is preferenceable with the family, and not to mention the eating disorder behaviors that you're able to see when those meals and those foods are put into place. So within, as I mentioned on here in program, it's not only eating with the families to teach the interventions, but also learning about how to plate and how what calories and foods would be medically necessary for the teen. We when we're refeeding, we find out our children are sick. We'll do anything, to get them to eat to whatever foods, whatever preferences they want, whatever amount they want, anything we will do. And so when we are refeeding or getting them back to health, we need to technically give them sometimes the calories that they do need typically, or even more. And that's really challenging to go from just plating your children, whatever we can get them to do, to actually, full calorie meals. It is very daunting to as a parent and caretaker to do that. So there's some work around that to do. Um, some interventions that we're going to talk about, which I do have a little those videos to show you, are direct prompts, indirect prompts. We talk a lot about rewards and consequences, distractions, and some other different like tools for you all to maybe hopefully try on through this process. And of course, providing education. So, parent management training is PMT. And parent management training is not that parents and caregivers don't know how to parent. You 100% know how to parent. You are good parents. This is nothing about that. This is just learning how to do it differently. Is like, okay, I've had like 3 or 4 kids and I parented. This is just how I parent. This is the way I do it. And then you have this one kid with an eating disorder, and you're like, I don't even know what I'm doing now. You like kind of question everything. And it's about just learning that and how to maybe shift to do things a little bit differently for this kid as you're trying to refeed. So, a lot about like nutrition too. There are a lot of myths and different things out there, which I won't get into in this seminar. I'm sure there will be others that Feast holds around this. But there are a lot of myths about nutrition, society, where you are in the world. And so those are things to really check the facts on as well. And so through those things, we are hopeful to be able to do the education to parents of actually like providing the education, providing the support, just like with Feast and their webinars and different resources to help kind of check the facts on things that we're hearing. Okay, so a little bit about parenting styles. So again, parenting styles, some people may have learned about your parenting style, but otherwise you don't learn this. Like nobody teaches you. A lot of times we parent out of like the way we were raised or parented, or we do the exact opposite because we didn't like it. So, unless you like learn about this stuff, like, right, you don't know. So there are a couple different parenting styles. And the reason, again, why this is important is because it is important through meal coaching to learn as parents and caretakers your parenting style, your temperament, and learn like, okay, is this working? Is this working for the meal coaching that I'm trying to establish? Or, you know what, this is kind of, oh, yeah, this is me. This is how I parent. Maybe I need to do something different. And so there are not right or wrongs with this at all. There's a place for all of this. This is merely just a way to kind of briefly describe kind of some of these ideas. So, authoritative parenting aims to balance the structure and the nurture. So, very much a little bit of like, okay, we're gonna, I can hold up the rules and structure, and I can kind of really be warm and loving. Often these parents, caretakers are supportive, validating, and also they are able to set these limits and boundaries. So this balance, and I will also say that these parenting styles can, wax and wane, if you will. Like they can shift. It doesn't mean that you are like this all the time, but the majority of the time, maybe this is how you identify. Authoritarian parenting, this style can often be a little bit more strict, maybe higher expectations, maybe more rigid rules. These parents' cares can often appear less warm due to setting more limits and boundaries. And this does not mean that they don't care or are not loving or want the best for their children. This is just kind of maybe how they approach or how they appear. So the style can offer a little bit more negotiation and uncertainty, with typically causing the teens with eating disorders to feel more anxious and overwhelmed. So, with this too, is that teens and adults as well, but specifically with adolescents, when they feel uncertain, typically when they feel uncertain and they don't know what's to come next, their anxiety rises. And that can cause them to feel very overwhelmed. So if they are like, okay, we got rules and boundaries, but that can shift and I can negotiate out of that, then that leaves some uncertainty, which then fuels some anxiety. So the indulgent parent, this one is the parent caretaker, often the ones maybe very involved, setting low rules and expectations, low boundaries, like willing to shift, willing to be extra flexible, willing to maneuver, willing to do things like last minute, very responsive to the teens emotional needs. They might really dislike authority and control. Like maybe these are parents, we're going to talk a little bit about behavioral contracting. And these are parents that maybe perhaps don't like rules and don't like consequences, often want to maybe do more rewards first, which again is completely okay to want to do that. So being able to shift with that. And then there's the uninvolved parenting or caretaker. These are parents for a variety of reasons are unable to be fully present for your teen. Now, if you're working full time and have other children and other things, it doesn't mean that you're uninvolved. These are parents that maybe have a lot of other things going on. Kids are very much on their own. Um, and they just are perhaps like, need the teen to build some autonomy and independence a lot quicker because of the family dynamics or because of just other, I mean, there's so many reasons, right, that this could be going on. So some reasons, not all, but some reasons that low parent self-efficacy could be playing a role. With eating disorders, the guilt for having caused the problem. This is just part of it. And parents and caretakers and families did not cause eating disorders. And a lot of us, FEAST, UCSD, a lot of these programs, right, and clinicians were trying to send this message, but it's still out there that parents and caretakers have not caused this. This is a brain neurobiology disorder. And there are some behavioral modifications that we can do to try to help shape this. Um, However, it is very that's the first thing parents do is proclaim guilt, right? When their kids are sick. The stigma associated with being blamed by professionals. I'm imagining some of you have experienced this with like other medical doctors or therapists or psychologists or hospitalizations or residential facilities or communities can put a lot of stigma still. Lack of knowledge about how to confront or disrupt the maintaining behaviors. So just not knowing what to do. I mean, because how are you supposed to know? How are you supposed to know what to do with these things when you've never experienced it or never had it involved? Some of you may have had these in your families, some eating disorders in your families, and perhaps there's like a little bit more of insight into that. But if you haven't, then I mean, how are you supposed to know? So just some education can make parents feel like ineffective. Lack of assistance in developing and managing approaches to disrupt these behaviors, and fear of doing harm to the relationship. That's big. Um, there is a new research article that recently just came out. In the interest of time, I don't can't have time to go over it, but actually declares that family-based therapy, Maudsley method, parents involved do not damage the relationships. I won't say that they're not strained, and I won't say that they are not difficult and challenging and through this process can feel disruptive. And I don't have a timeline of that. But for long term relationship goals, we don't have the research that suggests that relationships are damaged. Um, but parents do worry about that, understandably. There's also an uncertainty and ambivalence about treating the behaviors. It's hard to know. It's hard to know, is this eating disorder? Is this adolescent behavior? Is just this my teen? It's waving and waxing and like trying to kind of try to figure out what it is. So, some ways that we do to help improve some of this is parent training. And as I mentioned, this isn't a parent training on teaching you how to be a parent. This is like, you know how to be a parent. This is like, hey, you parent this way, and these things may work or not work for you. So, how do we build on that to make you feel more effective? Of course, attending like feast webinars and this involvement with these communities are key. Outpatient therapy, conferences, ways to kind of educate yourself within this community. Dietary information, like actually learning about the facts of nutrition, not necessarily what the social medias and all the things are telling us, but really kind of checking on that to see where the facts are. Mobilizing individual and combined parent strengths. So, if you are in a family dynamic where there's two caretakers available, or there's even just like multiple external, like grandma and aunts, or other people, adults who might be involved, really tapping into that, really learning like, hey, I'm really good at setting this limit and boundary. You're really good at plating. And so you do that, and then I will stick to the rules and boundaries. And so learning how to lean on each other's strengths if you have that available to you. Identifying emotional vulnerabilities and expression. So, a lot of this is like within here at UCSD, we talk a lot about DBT, which is also dialectical behavioral therapy, which really talks about like tapping in and learning into our own vulnerabilities. Like, okay, if I have a really hard day at work, or I'm really stressed, or I don't feel well, or there's things going on with me, I may not be able to show up the best for my teen later tonight when I'm trying to refeed them and trying to get them to do and hold the line and take the phone and all these things. So I need somebody else to do that. And I need to tap in to somebody else to do that. And then I might feel hopefully maybe more empowered tomorrow to do the work and being able to lean on people. Not everyone has this availability, and that is an extra challenge, right? When we don't have other extra supports. And being there's different ways to be able to take breaks for self-care with that and being able to monitor that. But if you do have the availability for anything, school teachers, like extra time at school, friends of parents, like being able to really kind of expand and think to help you. Providing guidance and support during meals. So that's what we'll get to, and we're going to talk about like how to continue to provide that support. So some barriers, again, the child passively avoiding refeeding, so not wanting to eat, actively avoiding refeeding, like sitting there, arms crossed, like not going to do it. The individual or family focused on non-food related items. So this is be like at the meal. The kid's not eating and the family's just kind of going about their conversations and not really attending to the child who is refusing to have their nutrition. Individual or families having food biases, judgments, criticisms. So we all have these things. So biases and judgments and criticism sounds like so harsh and so mean, but we all do. I mean, every one of us has food biases and judgments about foods and criticisms of what should and shouldn't we eat. And so the point of it is to really think about that and to really think like, wow, does my biases about this food, this type of food, interfere with refeeding my child? Does the judgment about this category of food, carbs, for instance, does that influence me refeeding my kid? And just kind of taking a look at that. Parents or caretakers who are not aligned. Alignment is key if you have multiple supports around you. It doesn't mean that you have to be aligned on every conversation or every situation, but if you can just agree to be aligned on the nutrition, that is a great start. And that you will support each other around what the expectation is for those meals to refeed your child. Um, I would say that parents and family members who are not only not aligned with each other, but not aligned with the treatment team can be a barrier to treatment because time goes by when you're just trying to get on the same page. And if you can't get on the same page, then behaviors just continue at that point. So it really is of the best interest of the teen who has the goals of weight restoring or maintaining weight, is that everybody kind of gets on board as soon as possible. No parent involvement or family members involved is a barrier. It's not to say that somebody or a teen cannot restore weight or get healthy or recover, but it is a barrier to not having a support to help do the hard and hold up those boundaries. Identifying emotional vulnerabilities and expressions are barriers as well. So we all have our own stuff. We're our own person. We have our own emotions, our own feelings, our own experiences. And it's really important to not just like brush those away, right? To be able to say, like, look, I'm feeling vulnerable right now, and this is what I need to do. Or just acknowledging that, like, hey, I'm like really frustrated about this. And then you can maybe still do the work at hand. So some mealtime interventions. So what we all came here for. So again, these are just some ideas. They're not all going to work for everybody all the time. They also might work sometimes. So I'm hopeful the goal is that these could possibly be some tools in your toolbox to try on. And at different stages and different phases of recovery, these might be more effective. And so that is also something to take note of. So, some mealtime interventions. So, setting mealtime expectations. So, when it is time to have a meal, we're going to talk about setting those expectations ahead of time. We're going to talk about direct eating prompts, what non direct eating prompts are, physical prompts, positive, negative incentives, um, anonymous comments, and then information providing and checking the facts. So, setting some mealtime expectations. What is the expectation goal for the meal? And why is this important? So, if you are, and this could be between you and a support or you and the teen, but involving the teen and saying, look, this is the expectation for this coming meal. The expectation, for example, if you have anorexia restricting type, is to eat 50% of your solid food. Let's say the teen has not been eating solid food, maybe eating 10, 15% of solid food. And the goal now is to do 50% of solid food. So you're telling the teen ahead of time. You're not saying it at the meal, you're not saying it like right before the meal or snack starts. You're saying it maybe earlier, being like, look, here, this is going to be the goal for dinner tonight is for you to do 50%. If you have bulimia nervosa, perhaps the goal is like to push away 10%. Or they can push away 10%. They don't have to, right? Because bulimia nervosa, those goals are going to be a little bit different. And so a lot of times you're working on hunger and fullness cues. And so you want to maybe say, hey, like I want you to be able to check in with your hunger and fullness. You don't have to eat 100% of your meal or snack. You can push away 10%. ARFID, for example, which is avoidant restrictive food intake disorder, for those that don't know, those are kind of more of our picky eating kids or have like trauma with eating. Perhaps the goal is they have a plate of preferred food and you have a carrot on the plate and you want them just to take one bite of the carrot and that's the goal. So it's really just establishing that, not just like, hey, just eat, right? Which we've all said. But just eat is very challenging. So having these goals are helpful. Who will be at the meal? So is it just going to be me and the teen? Or is there like two caretakers and three kids, then me and that other caretaker need to be aligned and on the same page. Hey, this is the goal for this meal. And if they don't do that, then this is the reward and this is maybe the consequence for that. And we'll talk about that later. But being aligned and we both agree, right? That they need to do 50%. Um, and if there's a problem during the meal, if there's negotiating, if there's food shoving, if there's behaviors, restriction, then you and the caretaker or the other carer, can be like, hey, I'd kind of talk to you in the other room while you maybe still have eyes on the teen just to make sure there aren't other behaviors happening. But you go into the other room and just be like, look, I thought it was 50%. That's not 50%. And then having that and be like, "Hey, how much more do you want them to do?" I want them to take like 3 more bites of whatever, of mashed potatoes, and that would be 50%. Okay. And then you go back in and you stay aligned. Mealtime rules. This is also something, could be like a nice, I don't know, I want to say like fun family activity, but I don't know, some kids really like to have the rigidity of the rules. Um, but it is something to perhaps do. And if you have other kids, you can involve them in this too, is to actually like write down family rules of like mealtime, like no negotiating, no discussing the types of foods, no discussing what's in the foods. Nobody saying disgusting or whatever that may be, or this is unhealthy, or making any of those comments. Maybe it's like everybody eats 100% of what's on their plate. Nobody leaves, nobody screams and yells, things like that. And then rewards and consequences. So we'll get more into this too, but having an external motivator can be really helpful when you don't want to do the thing you really don't want to do. And a lot of times with our kids with eating disorders, having a meal or a snack, gosh, it's like having like the worst thing in front of you. So it's like if you don't like tarantulas, it's like having tarantulas in front of you and you have to sit there and tolerate it. So like if I'm going to sit there with tarantulas in front of me on a plate, I want to get something for it. Like I want a reward for this, right? Because that would be very terrifying. So it's the same thing with them. It's like, okay, what am I going to get? Now, the goal is for you not to have to do that forever and always, but it is a helpful tool at the beginning. Or sometimes if they're attached to their phone or they're attached to something else, it's like, well, maybe they don't get that or they can't talk to their friend, until they complete what they want to do and they really want to talk to their friend because they had some stuff they wanted to talk to them about. It's really important then to say like, well, you can't have it then, if you're not going to eat because you need to have nutrition. Nutrition's the medicine, and you need to have that to be able to like talk on the phone or be able to do the things you want to do. And then what is the plan if your child doesn't eat or has behaviors? So this would be like another plan that you have either with yourself or with another caretaker as far as like, okay, if the child doesn't eat, then this is going to be again the consequence that happens. Or if this behavior happens, like what are the behaviors maybe we're really paying attention to right now? Sometimes there's a lot of behaviors and it can feel really overwhelming. So maybe what are the top 2 or 3 that you really want to work on? Looking at the goal of like with anorexia nervosa, it's going to be like weight restoration most likely. So getting them to the weight that they need to be in, what is our primary goal? Is eating 100% of the nutrition. And so maybe right now is maybe you do just do the foods the family eats. You don't need to do huge challenges, but maybe you do still give them the food that they need to eat. And the goal is to complete the nutrition. And if they move food around on their plate or they gripe and moan, or maybe at some point you're just kind of overlooking that right now just to get them to eat. And then we'll start working on those other behaviors. Okay, so some direct eating prompts. And I do have a video again with this one. And again, they don't talk a lot, um, but so you just might need to again turn your volume up. So some direct eating prompts are comments aimed at directly prompting or pressuring the adolescent or young person to eat. So that could look like, stopping all conversation and really focusing on the adolescent who is maybe having behaviors of restriction or moving food around or just playing with the food or just sitting there staring at it. You might say, like, I need you to pick up the fork. I need you to pick up the fork. And you just really say that until you kind of continue to say that annoyingly and they do it. You can say, I want you to start with the toast on the bread, on the plate. You need to take bigger bites. Take the last sip. So you're directly telling them what you would like for them to do. So this video I have just models the direct eating prompts. These are three therapists that used to work with us. They did like some practicum stuff with us. And so they're modeling this. They're very short videos.
Pick up the spoon. Pick up the spoon. Pick up your spoon. Thank you.
Take a bite. Take a bite. I need you to take a bite. Take a bite. I need you to take a bite. Thank you.
And here is another example.
Chelsea, put your feet down. Both feet. Turn towards the table.
Actually, this one might be more the physical prompt. So let me move on. I can come back to that one. So non-direct, we'll come back. So non-direct eating prompts will be comments which are encouraging or suggesting regarding eating. So I will say that some teens do not like this. So I think it's a matter of where you are in recovery and where you are on your eating disorder journey. So that is something to take into account. Nobody really likes the direct prompts, but those are just usually necessary at first. But some do like encouragement and some do like what they feel like they would say support, and others don't like it. They feel like it's cheerleading, and that is i- invalidating to the eating disorder, which makes them feel bad. And so this is something like, hey, do you like it if this would be helpful? And if it is, this could be something that you could try, is to say things like, keep going, you can do this. I see you working hard, nodding. I will sometimes with teens, if I have an agreement with them and I see them doing something hard at a mealtime, I sometimes will just like kind of nod at them and walk by so they know that I know that they did something difficult. Or I might, if they like a high five or something, I might do that. But it really depends on kind of the relationship too.
Keep going.
Do you want some more? More than this?
You got this.
Can you take bigger bites?
Okay. And then we have the physical prompts. So the physical prompts are prompts to encourage eating or drinking. So again, when they're like pushing the food away, you might grab the food and bring it towards the adolescent. If they are pushing their chair away, you might get up and actually help scoot them closer. And carers or parents may also change their seating. So this goes back to the structural, the hierarchy again too. is that perhaps like you have a teen and two caretakers, let's say, for example. You have the teen and then the two caretakers sitting next to each other. A good example might be is to, if the teen is refusing to eat, is to have the caretakers actually sit on either side of the adolescent, putting the pressure on. They usually don't like it and it's uncomfortable, but once they can feel and they start eating, like, okay, if you eat, then I'll go back and sit on the other side, or I'll go and like move, but you need to eat, and this is what we're doing. Then sometimes, not again, not always, that can help put the heat on. Um, Food drops on the floor, gets thrown, whatever, flinged, is getting a replacement for the food item. Changing locations of the family meal. So if you are always having it in one location, perhaps if you can even use this even as a little bit of a reward too, is like, okay, we're going to go outside and eat this time, or we'll go eat in this other area, or we'll go and watch television and do this, but you need to be able to commit to eating the food. And in the interest of time, I'm just going to kind of keep moving along a little bit. Um, so the positive and negative incentives. So along with the mealtime strategies is really these positive and negative incentives to help again externally motivate, because, or externally, I should say, suggest behavioral change, because people oftentimes with eating disorders, especially adolescents, do not have internal motivation for change. So sometimes they do. So I'm not saying never. They sometimes really want to do the work, and that is great. That like really helps the process. But if they have external motivators that they are interested in, that is a helpful tool. So describing those things. So it could be with the adolescent, if they are externally motivated, like if they do want to get back to dance, or they do want to get back to soccer, or they want to get back to school with their friends, or they want to have parents and caretakers back off, whatever it is, then, being able to say those things too during the meal time. Like, you need to eat and feel your body. If you don't do that, you can't dance. Like, let's pick up the fork. So it's a way of intertwining almost direct prompts with also these incentives. Um, if you don't eat, this is maybe a negative incentive. If you don't eat, then I'm taking your phone. And you have to be able to follow through with that if they don't eat. So if they don't eat, you do take their phone for whatever time that you said, and then you take it away and you give it back the time that you said. So again, you're building that trust of two of look, like I'm going to hold up my end and you're going to hold up your end of the bargain kind of with this and that incentive. So from the eating disorder lens too, within somebody who has an eating disorders, there is a lot of thoughts and a lot of negative, what we call noise going on. You can call it the eating disorder, you can call it kind of whatever you'd like, but there's a lot of negative ruminating thoughts and things happening. So they might even be wanting to get better. They may want to do the meal. They may want to do the thing to get back to dance, but they just are overwhelmed by the thoughts. And so they sometimes just even need somebody to remind them, okay, I need to do this thing so I can get back to this thing that I love. Information providing. So this is another strategy as far as providing information. Again, some kids like this or teens like this, some don't. This is kind of a check the facts and checking it, when you're doing it. But some really are scared about the medical complications that have happened to them in their eating disorder. And so when you can really use that, not to scare them, but just to remind them when all of that noise and eating disorder thoughts are happening, reminding them, look, you need to eat because you need calcium. You need calcium for your bones so you can go back to dance. If your bones are not well, then you can't go to dance because they're not strong enough and you're going to get hurt. Your heart rate is too low. You need nutrition to stay out of the hospital. You and sometimes that can be scary. Some kids don't care in their eating disorder, and some this does not work. But there are some that are really motivated by this information. So I just wanted to touch in on a little bit of like the RFID meal coaching as well. So it would be along the same lines as far as parents asking what the goal is for the meal. What is the expectation? Just like with somebody with ANR, is this like for them to eat 100% nutrition? Is this an exposure? Is this part of the nutrition calories they need? Or is this just like the exposure of the meal or the like take a bite of the carrot, for instance, that I used earlier? Um, so sometimes mealtime coaching can be a little bit confusing. Um, because with somebody with ANR, we want them to complete 100% of their nutrition. Somebody with RFID, depending on what their goals are with weight restoration, we might not necessarily be requiring them to do 100% of their nutrition. Typically, without going into it too much, as somebody with RFID typically wants to gain weight and wants to eat the food, there's just barriers there. So again, saying, okay, I want you to complete maybe 100% of your food here, and I just want you to take one bite of the carrot because the carrot's the exposure. During weight restoration, providing food that patient prefers is appropriate. So for RFID, if they need to gain weight, get them, it's really appropriate to at the beginning just do all the things they love. So if they love chicken nuggets and mac and cheese, just do that. And then we'll start with like the exposures around it. Where somebody more with ANR, we typically like to say you don't have to challenge them with their like most challenging item at first, but you do want to present them with the family foods that they have eaten. Meal coaching for bulimia or anorexia nervosa with binge purge type. It's a matter of thinking about are they on weight maintenance or weight restoration. So if they're on weight maintenance, then you might want to talk about push away, like having them kind of learn their hunger and fullness cues, exposures to trigger foods that might be challenging, intuitive eating, mindful eating. So you might be really focusing on these things a lot sooner. If they're still needing to gain weight, then you'll want to think about like, are they meeting their goals? Asking parents, are these foods that are challenging or triggering to the patient? Because with somebody with these disorders, we can't assume that something's challenging for one person versus another. So it's really important to ask. And what are those foods? I've kind of preferenced some contracting ideas, which honestly could be a whole webinar on itself. But as far as like how to do that, so it really is helpful in my experience to do the behavioral contracting outside of a mealtime and just really prefacing those goals that the family has. So it's taking about 2 to 3 problems at a time. I kind of mentioned that with the eating disorder behaviors too. It's creating a list of like, okay, these are the things we want to work on, but we're going to kind of work on these first 2 things: weight restoration and eating 100% of our nutrition per se. Um, so converting some of the problems into concrete rules. So like, again, I was talking about mealtime rules, adding those in, creating consequences as we've talked about, like you can't hang out with your friend, you can't use your phone, um, and how to integrate the positive and the negatives on the contract, including your teen in it. The family, I help often support the contracting, but then we say, hey, teen, I want you to take a look at this before we put this into effect. Get a red marker, whatever you need to do, and add your 2 cents in there, and then we will go from there. But we want to be collaborative. And then oftentimes we will change things just so the team feels also that they have a voice a little bit in it. Be consistent and follow through. I always have families do the contract themselves. I really prefer not doing it only because I don't know I know what might work. I can offer suggestions, but I really want the family and the parent and the caretakers to feel like, no, I really do feel like I could take their phone. Because if you don't feel like you can take their phone, then we can't have it in the contract because that isn't going to work for you or for the team. Catching your teens doing right things. So after a meal or something, maybe perhaps here in program, for instance, I will say to the teen, wow, you are like working so hard today. I looked at the what we have like our mealtime percentages. I'm like, you are really you're like conquering it today, you know? And so I'm saying it outside of it, but I'm letting them know that I'm hearing them do good. This is a little bit about a contract looks like. Again, I'm happy to be sending these slides as well. Just write on a little bit over Judy, but and then these are our references as well.
Thank you. This was a lot of information.
I
Um,
know.
Given amount of time. So I'm really glad that you're sharing the slides so that people can kind of review it more,
Yes.
at their leisure. So someone had asked about the link to the study that says that FBT doesn't create harm in the parent-child
Mhm.
relationship. So
Yes, I will add that into the references actually,
perfect.
because it's very new. It's a new study that just came out. So yeah, I don't think I have it on this one, so I'll add it in there.
Perfect.
Yeah.
Someone else asked, which is a really good question. What happens when they throw the spoon or they storm away from the table? What do you do?
Hmm. Yeah. So if they throw the spoon, they storm away. Oftentimes, you can use some techniques as far as to maybe perhaps give them some space. You might give them a little bit of time to cool down, to utilize maybe some other skills that they're learning. Maybe like I mentioned, we do DBT, so that maybe they'll do just to relax and then go back and tell them to come back to the table. Again, if they refuse to do that, let's say they just refuse to come back to the table, then the goal would hopefully maybe within the contract is you would have some other consequences for that. So that, okay, if you don't come back to the table, then this is what you're going to lose. If you do come back, this is what you're going to get. Like, okay, this is hard, but if you come back to the table, you'll get your phone. So then if that's something that happens a lot, like if they throw the spoon, they get up from the table often, then when you have your hierarchy of behaviors, you might want to say, along with eating 100% of your nutrition, you have to stay at the table. And if you stay at the table, then this is what will happen.
Okay, thank you.
Yeah.
I have a question personally.
Yeah.
Um, in the presentation, you had referenced 50% of food as a goal for anorexia.
Hmm.
And then you kind of also said, like, between the two parents, they have to come to an agreement on what that 50% looks like. I'm curious as to why it shouldn't be 100%, meaning
Hmm.
50% is really subjective because how
Hmm.
many more spoonfuls of mashed potatoes does the kid need to complete 50%? Why wouldn't 100% be the goal?
Yeah. So 100% is the goal, but sometimes depending on where they are in their eating disorder, we might need to start a little bit smaller. So if you have a teen perhaps who is not eating any solid food, let's say they're just coming out of a hospital situation and they may be on an NG tube or they might be on like boost nutrition, they haven't done any solid food. You might say, "Oh, okay, to start, like for the next like couple weeks, this is going to be our goal is 50% to get to 100%." Now, if you have a teen who's been eating solid food intermittently and had maybe isn't been in the hospital with an NG, who has been eating food but restricting like meal and snack, but then doing like 100% of dinner or things like that, then yes, you actually might want them to be like, no, they can do 100% because they do 100% of these meals. So that needs to be our goal. So it really just depends on where the teen is at in their eating disorder.
Okay, that makes a lot of sense.
Yeah,
Uh,
thanks for asking that.
okay. So given that I don't see more questions, I think we're gonna close up.
Okay.
So I want to say thank you again so much for this amazing presentation. It was really so incredibly informative, and I know it's a topic that so many parents struggle with. So I really
Yes.
appreciate that. I just want to let people know that if you enjoyed today's webinar, and if you appreciate the free services that we provide for the community, we would really appreciate it if you would donate. If you can, you can go to our website to the donate page and you can give whatever works for you. So thank you so much. Unfortunately, I see that there are more questions, but we're just going to close up here. And I want to invite everyone to come to our next webinar. It's going to be on December 3rd. It's a topic that I think is really fascinating. It's family-based treatment for young adults, parents as partners in recovery, because so many times parents are like, oh, we can't do FBT because our kid is not a child, they're a young adult. So this is a really great topic. She's a really great speaker. Um, I'm just going to just take one quick look and see if there's any. Okay, one quick last question, which I don't usually do, but I feel bad that there are more.
Yeah.
Do you host a parent support group? I thought that was a really good one.
I'm sorry, what was that?
It says, do you all host a parent support group? Now,
Mm,
we do from Feast. You can see it on our website. Does UCSD provide a parent support group for parents who are not in your program?
no, we don't.
Okay, great, thank you. But we do.
You do, yeah.
We provide two support groups a week online for parents. One of them is during the daytime hours, and one of them is during the evening hours, so that parents can find the time that works for them. So feel free to go on the Feast website and take a look at our support groups because they're really, really good. And I'll just plug really quickly. We also have a sibling support group
Mm,
for siblings ages 13 plus. That is amazing. There's a peer-led support group. Also, once a week, it's virtual. So if you have a 13 plus year old who can really benefit from support, then please take a look at our website and send them our way. So again, thank you everyone so much for attending. Everyone have a great rest of your day. Thank you again, Kristen, and hopefully we
you.
will see you all next month.
Thank you all. Good luck.
Okay. Bye.